The clinical swallow evaluation is a preliminary assessment of a patient's swallowing status. It determines the least restrictive diet for the patient that prevents aspiration and helps determine the need for an instrumental assessment and which one. Step 1. Gather information about the client's current status through medical records, client or caregiver interview or questionnaire, or report from the doctor or nurse. You want to identify the client's neurological and medical status, for example, any recent strokes, neurological disease, history of aspiration pneumonia or medications. Identify the client's feeding status and current nutritional means, if they have a special diet, if they're able to self-feed, or if they have reflux. Be aware of dietary limitations, for example, food allergies or diabetes, and social or cultural history or habits. You also want to identify the client's cognitive status. Are they alert? Are they able to follow directions? Note the type of dysphagia, liquids, foods, or pills, the onset and progressions, and prior management of the dysphagia. And finally, identify associated symptoms, voice change, weakness of tongue, lips, limbs, etc., any coughing, throat clearing, weight loss, or dehydration. Step 2. The oral mechanism exam, which assesses the patient's range of motion, strength, symmetry, coordination, and sensation of the jaw or mandible, lips and cheeks, the tongue, and the velum. The SLP provides oral care as needed in order to prevent aspiration pneumonia. Jaw or mandible. Assess symmetry by examining the patient's jaw at rest. Assess range of motion or coordination, having the patient open and close their mouth, and assess the patient's strength by having them open or close their mouth against mild pressure. You want to note any noticeable groping and be aware of dentition. Are there any abnormal occlusions, missing teeth, or dentures? Assess the patient's lips and cheeks at rest, having them pucker, smile, then pucker and smile to look at coordination. Assess strength by having the patient hold air in their cheeks, and again having them hold air in their cheeks against mild pressure. Having them say ma 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 shows coordination, and also brush the lips lightly with hot, cold, sweet, and lemon-flavored cotton tip swabs to assess sensation. Make note of any obvious drool, which can indicate a weakness, and discoordination may be signs or symptoms of apraxia. Assess the patient's tongue at rest during protrusion. Assess strength by having them push on a tongue depressor or putting their tongue in their cheek. Have them lick their lips. Assess coordination of the front of the tongue by having them imitate la 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 la, and the back of the tongue with ga 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 ga. And you can also assess sensation by recording their response to various stimuli such as hot, cold, sweet, and lemon-flavored cotton tip swabs. You want to note if their articulation seems normal. Is dysarthria present? Note any noticeable fasciculations, tremor, or atrophy. And again, discoordination may be signs or symptoms of apraxia. Assess the patient's velum at rest during a sustained ah, and assess their coordination during ah, 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 ah. Step 3. The saliva swallow. Step 4. Administer ice chips. Step 5. Administer water via spoon, cup, and straw. Note: use thickened liquid if the patient fails on thin water. Step 6. Food trials. You'll want to administer a thickened liquid such as pudding or applesauce, a soft chewable such as a cracker, and a hard chewable, such as a bagel. There are many things to look for during the exam. Abnormalities may indicate an issue. Does the patient have appropriate pre-feeding skills? Are they able to open and close their mouth to accept food, take food from a spoon, bring the cup to their mouth, suck from a straw, and are they able to keep food and liquid in their mouth? Deviant behavior may be indicative of oral apraxia. Patients with apraxia have poor motor coordination and automatic tasks are easier. If possible, have the patient feed themselves. Note the patient's oral skills, including lip closure, bolus preparation and transfer, and clearing of their mouth. Deviant behavior may indicate weakness of their lips, cheeks, and/or tongue, which may be a cranial nerve issue. This could lead to anterior spillage. Note swallow initiation timing, which is the time required to propel the bolus posterior to initiate the swallow. This should be about 1 second or less for thin liquid. Increased time may be caused by reduced sensation and could lead to premature spillage and aspiration or penetration before the swallow. Notice the amount, timing, and consistency of hyolaryngeal elevation and excursion by palpating. Deviant behavior may be indicative of reduced tongue-based retraction and may result in decreased pressure during the swallow, causing pharyngeal residue and/or reduced epiglottic inversion, which could cause reduction in airway protection. Note the number of swallows, which is usually 1 swallow for liquids, 1 to 2 swallows for soft, moist foods, and 1 to 3 swallows for dry, thick foods. Increased number of swallows may indicate that the patient is sensing residue and may be caused by a weak swallow, reduced pressure, poor pharyngeal closure, reduced hyolaryngeal elevation or excursion, reduced tongue-based retraction, or cricopharyngeal dysfunction. Also, pay close attention to any signs or symptoms of penetration or aspiration on each consistency. Penetration or aspiration indicates poor airway protection either during the swallow, before the swallow caused by premature spillage, and/or after the swallow caused by residual pooling. Signs or symptoms of aspiration include coughing of saliva, liquid, and/or food, chronic throat clearing, especially if during a meal, and multiple swallows. The following may indicate silent aspiration: a weak or breathy voice, chronic gurgling voice or a wet vocal quality, watery eyes, a facial grimace, or respiration changes, such as shortness of breath or a drop in oxygen levels. In order to reduce the risk of aspiration pneumonia, the SLP should not administer food if any of these symptoms are noticed, if the client cannot handle their own secretions, or if the client has a high risk of silent aspiration, such as a neurological disease or dementia. In this event, a video study may be warranted.
I will be covering items needed for a clinical swallow evaluation. The first items you need will be disposable gloves, as there is a good chance you will be coming in contact with a patient's secretions such as saliva. A tongue depressor is needed for the oral MEC examination, as well as looking in a client's mouth following swallowing to check for pocketing or residue in the mouth. Chew-Vets are a good idea to have, as occasionally you will need to swab out a patient's mouth prior to the swallowing evaluation. A couple of different cups for your thickened liquids and also for your ice chips and water. Spoons for your liquids and your solid foods to feed the patient. Straws for consuming liquid. Paper towels or some sort of towel in case there's any spills, messes, or wiping off the patient's face following a swallow. Thickeners are needed to thicken up liquids. For example, a teaspoon is added to liquid for nectar thick, which would be about the consistency of V8 juice, and then about a spoon and a half is needed for honey thick liquids. Next, you will need a stethoscope, and you place the stethoscope at the level of the vocal folds and you listen for sounds associated with swallowing. And this is useful to determine if a swallow response is delayed during your clinical swallow evaluation. Trials of different foods and consistencies of liquids will provide the clinician with information about the coordination of a patient's swallowing muscles. With each swallow, you look for timing, laryngeal elevation, how many times they swallow to clear the bolus, and if there are any signs and symptoms of aspiration. The first thing that you begin with would be ice chips, and this is because they are relatively safe and they elicit a good chewing reflex because of their texture and their temperature. Once it's been determined that the patient adequately elevates their larynx and there is an adequate protective cough, then the clinician can proceed to using other liquids and consistencies of food. Water can then be given by spoon, have them drink from the cup, and then also drink from a straw. And having them consume liquids in various ways may yield differences in their performance of their swallow. For example, if you drink through a straw, it requires a longer and more coordinated airway closure mechanics than it does, say, from drinking from the spoon. Then you would move on to your thickened liquids. You can use different types of juice just because a thickened juice is easier to drink than a thickened glass of water. Next would be soft mechanical foods such as applesauce, pudding, or yogurt. And then finally, you would use some sort of harder food like a cracker. And then you would watch again for laryngeal elevation, timing, number of swallows it takes per bolus, and also signs and symptoms of aspiration. And then those are the items necessary for your swallow evaluation. Thanks.
So we are ready for a clinical examination. We have our thin liquid and thickened liquid ready to go. We have a pureed, a hard solid, and a soft solid. We have a spoon and straw ready to go as well. And we're going to start off with a oral mechanism exam. How are you today, Erica?
I'm doing great. How are you? Good.
Okay. Start by spitting out your tongue. Now up and down and side to side. Okay. Straight out and go side to side. There you go. Okay. And open. And then stick your tongue out. And say ah, and e. And that doesn't work. You can get that out. And if you push against the side of your cheek. Okay. The other side. Okay. Now go ooh, ee, ooh, ee.
Ooh, ee, ooh, ee.
Okay. Now fill your cheeks with air. and resist my, there. Good, good. Okay, I'm just going to have you swallow your saliva. Okay, it feels good. And now if you will just take for yourself and swallow the water. Okay. Okay, and again. And count to 10 for me.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay. Take a drink as you normally would. And count to 5.
1, 2, 3, 4, 5.
Okay. And if you would drink, here, I'll take the spoon for you. And okay. All right, and count to 5.
1, 2, 3, 4, 5.
Okay. And now just all right. If the client had aspirated on the thin liquid, we would move to thick liquid. But since she did all right with the thin liquid, we'll move to a puree texture. And we have applesauce. I'm going to have the client feed herself. Okay, and count to 5.
1, 2, 3, 4, 5.
Okay.
Thank
So,
you.
yeah, just okay. All right. So did it take you both swallows to clear it?
Mhm.
Okay. And she did well on that. So I'm gonna have you take a bite of cracker.
Mhm.
And now. Okay. Now for our hard solid. For our hard solid we have chunks of pretzel. So cleared with one swallow? Okay. All right.
And that's.
You did wonderful.
Oh, thank you.
Your swallow is perfect.
Today I would like to talk about the limitations of the clinical swallow evaluation. One of the limitations is identifying patients who aspirate, the reason they aspirate, and the amount of aspiration. A clinician may suspect aspiration, but many patients are silent aspirators who do not respond in a typical way, such as coughing. The most appropriate therapy cannot be determined because of the limited view of the structures. If the pharyngeal swallow takes longer than 1 second on thin liquids, the clinician cannot assess what is occurring physiologically at the same time. When compensatory strategies are attempted during a bedside swallow evaluation, the clinician cannot be certain whether or not the strategies are working properly. Also, what you cannot identify at a bedside swallow evaluation is Zenker's diverticulum, osteophytes, the retention and residues and wear, epiglottic dysfunction, PES dysfunction, structural function, and obstructions cannot be identified. Moving on. When to recommend a modified barium swallow. Patient who will not tolerate fees. When you suspect an oral stage problem. You suspect an esophageal problem. Globulous complaints, frequently esophageal. You need to identify which bolus propulsion force is weak, for example, the tongue, or laryngeal elevation. You suspect aspiration during the swallow. You need a better impression of the amount of aspiration. Clinical findings better with MBS than fees. Coordination of oral and pharyngeal movements, arytenoid to epiglottis contact during the swallow, completeness of epiglottic inversion, cricopharyngeal function, and esophageal clearance. Moving on, when to recommend a fees study. When a patient would experience problems with MBS, position, a problem with transportation to the X-ray department or scheduling. The patient has severe dysphagia with a very weak or potentially absent swallow reflex. If you suspect post-intubation or laryngeal trauma, in a short period of time, the exam needs to be repeated. The patient could benefit from the visual feedback to learn maneuvers. The patient is having a difficult time handling their own secretions. You suspect aspiration after the swallow. You suspect LPR. The patient needs an extended evaluation. And the clinical findings are better with fees than MBS. For example, the anatomical abnormalities, velopharyngeal closure, status of secretion management, ability to achieve airway closure, pharyngeal-laryngeal sensation, the exact location of spillage and residue, better visualization of penetration, and vocal fold or arytenoid movement would be better seen with the fees than the MBS.
And just feel your swallow if you'll just swallow your spit.
An alarm! This is a fire alarm.
Really?
Are you kidding me?